doses of commonly utilized opioids for our patients. Again, we're just going to highlight a few key points of opioids that we're going to see. Okay, so start off with a wonder why here. And this is something you're going to hear frequently throughout your fellowship and moving forward, and probably a phrase that you yourself have used or will use. And when in doubt, when we're talking about medications, we say start low and go slow, right? I know it's one of my favorite kick the can down the road kind of questions. When I get it, I get to answer this way. Would you ever wonder why we use this phrase so often when we're starting symptom medications in our medically fragile patients, right? I really do think there are reasons why we often will say that. And the hopes with our talk today, starting off, is to highlight why there's so much uncertainty with medicines that we might feel more comfortable in patients who are a little more, kind of stable. Okay. So there are a lot of physiological considerations that go into how medications are used and how they're dosed, and that's obviously no surprise to you. But there are a lot of physiological changes that go on in our hospice and palliative care patients. Now, a lot of these are analogous to those changes you see in patients, our geriatric patients. They're not necessarily the same, but they share some similarities. And I recognize that many of our palliative care patients, some of our hospice patients, aren't older from a prototypical age perspective, right? Though their bodies may function older than they really are due to, again, some medical frailty. So some of these changes that might alter the way we think about medications and how they work are things like changes in cardiac output, changes in blood-brain barrier permeability, so we can see increases in that permeability, which medications that normally wouldn't get there are, or medications that do are now getting there in higher concentrations. We see altered baroreceptor response to drops in blood pressures. Why is that important? As our patients maybe you already have a baseline feeling of being dizzy or dehydrated, and now that's worsened, and so higher risk for things like falls. And we can appreciate there are going to be changes in renal and hepatic function as well. We're going to go through some of these a little more one by one to really think about how we might go about dosing and or modifying some of our medications we will use from a symptomatic perspective in our hospice and palliative care patients. I would urge you to go ahead and put questions in the chat if there's something else that comes up. And we want to talk through it. If I'm not sure if someone wants to help moderate, please stop and pause. I'm very happy for this to be a conversation if good questions come up. So the palliative care patient, right? So thinking about how we use and dose medications, why do we start low and go slow? And why do our patients in palliative and hospice care seem to be at higher risk for adverse effects from medications? We can appreciate there are pharmacokinetic and pharmacodynamic changes that occur as their bodies change. And PK and PD are just big fancy words as pharmacists use to make ourselves sound a lot smarter than what we really are, okay? Pharmacokinetic just means really what does the body do to the medication? So we'll go through that. So it means absorption, distribution, metabolism, excretion. So when a patient is given medication, what does the body do to really get it out, to respond and get it out? Pharmacodynamically means what is really happening at that receptor level that the medication itself is doing to the body. So there are changes, and those changes do happen, and they alter the way we have to think about using our medications. We also know that our patients often have multiple disease states, which means more medications, which means more medication interactions. Given the increasing complexity of often our patients and regimens, there are compliance concerns. And I don't necessarily mean for nefarious reasons or concerns. It's just, it can be really hard to take the medications as patients are supposed to. So you can see sometimes under or over compliance. It also results in our patients having responses that are different than we were hoping for. So pharmacokinetic changes with absorption. Again, so what might happen with our patients that affect the way our medications that would normally be predictable or a little less predictable? So with oral absorption, primarily we think about changes, and that's due to decreased GI blood flow. So changes that might affect absorption from our oral administration are things like reduced saliva, increasing gastric pH, possibly seeing changing in our gastric emptying time. This can increase exposure to irritating medications. And again, there's also a risk for GI, decreased GI motility. I'm not saying this is occurring in every and all of our patients, but what I am saying, these are things that we might need to consider. They're going to alter the way we think about using oral medications or how we have to dose them. Okay. And this is very different than a traditional patient that we might see in a classic internal medicine kind of environment. Again, kind of other reasons for absorption or absorption changes can increase the time it takes for a medication to absorb, but it doesn't necessarily affect the overall amount that does get absorbed in most situations. So as we're thinking about our symptom medications, this can be important when we're thinking about reassessment, right? If we would traditionally think that, okay, this medication should see an onset in roughly 30 minutes, well, maybe now it might take a little longer. And where we might think it might peak in 60 minutes, now maybe it takes 90. And these sort of things, honestly, I have seen change as I have been in hospice and palliative care. Years ago, I was taught opioids peak in 60 minutes. Our traditional oral opioids peak in 60 minutes. We recognize that in our patients who are more medically fragile, it can sometimes take up to 75 to 90 minutes in some scenarios. So that might change the way we think about assessing our medications. And so we're giving them adequate time to really work. I think a lot of us who've practiced in hospice and palliative care have always heard with our transdermal administration of medications that absorption will be altered due to changes in fat concentrations in the skin, as well as reduced blood flow, right? I think that's something that probably all of us have heard. And we recognize that is true. You can see decreased blood flow and you can see oftentimes decreasing in adipose tissue. What we do know is it does affect absorption, okay? But we're not exactly sure how. There is some changing data to suggest you initially may see a little bit of erratic absorption, but the reality is in our patients who have a little more cachexia, medications still do get absorbed. There just may be a little more of an initial concern about what happened. And this flies in the face for everything we've been taught for years. Again, I can't say at the high level of confidence that our transdermal formulations are completely going to be effective and safe. But I think we now know more than we did years ago to say that there's not a strict contraindication due to these changes that we know we see in our patients. I have increasing confidence using things like fentanyl and buprenorphine patches in our patients. What about distribution? Okay, and then there are a lot of things that affect distribution, and I'm not going to talk about all of those. We're just highlighting some of those things that should come to mind as we're thinking about how we select medications and dose them. Reduce cardiac output, right? And this reduces perfusion to our key organs. And if that is where your medication is working, again, that might help us understand why this just isn't working as well as you might have seen in a patient in internal medicine. Okay, maybe we need a little higher concentrations of particular medications if where they're working requires perfusion to some of our organs. We know in our older patients, so if we're thinking about those are our older patients in hospice and palliative care, you can see this really affect the way we think about dosing medications in our geriatric patients. So cardiac output, if we know that's reduced, can impact the way we think about that within our patients. So distribution, we also know is impacted by our different various protein levels. One example would be albumin levels. We know those who are chronically ill or malnourished have reduced albumin levels. We have a lot of drugs that are highly bound to proteins. So if we have highly bound protein drugs and now you have reduced levels of albumin as an example, that means you have increased concentrations of medications within the serum, meaning you might see increased effect and possibly increased side effects. So all this goes into how we have to think about dosing our medications. So I hope you're having a little better appreciation for why when you ask me a question and we say, hey, Mr. Pharmacist, how do we dose this? And I say with a smile, low and slow, it's not because I'm trying, it's really because there's such an individual approach, and we can, for certain medications and classes, I can give you a much better answer knowing that. But sometimes we just have to be a little more cautious due to some of these considerations. Metabolism, oh boy, right? If we think about metabolism, I so wish we had equations like we do with excretion, right? With excretion, we've got some calculations, the cutoff being one, to help guide us with some level of confidence, right? Metabolism, not such, right? Up to about 10 or 15 years ago, the FDA approval process for drugs with hepatic impairment was pretty soft. They didn't have to do a whole lot with that. So you don't see a lot of guidance, okay? Folks are having changes in their hepatic function. Within the last 10 years, there's a little more structure to what needs to be done, but it's still pretty generic. So what we know as our patients begin to trend down this palliative care pathway and particularly as we get into the hospice pathway, we know that can alter things like hepatic blood flow, which in essence means you are shifting blood away from the liver, which is a major source of drug metabolism. So you're increasing risk of concentration of drugs, or they're maintaining a larger percentage of drugs there. We have reduced hepatic mass, and that's going to greatly affect our hepatic enzyme pathways. Do we have changes in the intrinsic ability of our enzymes themselves to work? Well, I think we're learning more about that as well. Sufficient to say that yes, especially if we know the liver is what I call angry, or is just chronically not working well, it all absolutely is going to alter metabolism and the way we think about medications. So changes in metabolism lead to both reduced first-pass metabolism as well as clearance of medications. This has dueling concerns. You might ask, what do you mean? Well, if the drug itself is active and we reduce first-pass metabolism, more medications getting to the site. We'll get to that example here in a little bit. That's something like we think about with a medication, what we call with a high extraction ratio, meaning a lot of the drugs are extracted. I think you have opioid conversions next, using morphine as an example, okay? When you give 10 milligrams of oral morphine, okay, using just very simple kind of math, only 3 milligrams of that, roughly 3.3 milligrams of that, gets to systemic circulation, meaning the liver is clearing 2/3 of that drug before it ever gets to site of action. If you have an individual where the liver's not working very well, now you're going to change how much is being reduced through first pass metabolism. And now maybe 5 milligrams getting to some circulation versus 3.3. So it changes the way we think about dosing morphine, okay? Now, if you have a prodrug, meaning a drug has to be converted from an inactive drug to an active drug, now you decrease the efficiency of that medication. Okay, so you can see how it greatly affects how you think about dosing medications. Okay, so it can change a lot of things and the way our patients are responding to medications. So I highlighted this earlier, particularly with our symptomatic medications, we need to be aware if it's a high extraction medication in a patient who's having poor hepatic function. I will tell you, this is a lecture of its own. In fact, with our what we call our Columbus conspiracy theory here in Ohio, I spent an entire hour just on this talk yesterday with our fellows. And with that being said, when folks are having impaired hepatic function, It is much more of a concern with phase 1 metabolism. That's your classic hepatic enzyme CYP3A4, 2D6, 1B, 1A2, and so forth. Then it does phase 2, which is glucuronidation. But we do know that glucuronidation is still impacted, okay? Phase 1 more than phase 2. That's why you'll hear us say in a patient with hepatic impairment alone, we like drugs that go through phase 2 metabolism, like morphine as an example. I'm not saying it's not impacted, it has less impact, okay? What about excretion? I think we feel a little more comfortable with this. We know that drugs can be dosed a little more confidently when we all have an idea of what that creatinine clearance looks like. Whether you're calculating that from a serum creatinine, or if you have your other 24-hour measurements that you can use. But we do know that you see changes in both reduced renal function and reduced renal blood flow that affect the way medications are excreted. Now we have a handful of medications that have heavy excretion pathways outside of the urine and kidneys, but for the most part, many medications are excreted through the urine. So we have to be aware of how we handle that. We also know with our most common calculations are limitations of how we calculate serum creatinine as well. So here, thinking about how we use creatinine clearance in patients who are chronically ill. We know that muscle mass is one way that we use, in essence, thinking about serum creatinine. So if a patient is chronically ill and their muscle mass is low, that's going to affect the way we think about using our serum creatinine. And this, again, itself is a very fun, controversial debate to get into. Some folks will round their serum creatinine up to give them an idea what it might actually be looking like, to give them a sense of we need to change medication. But rounding has its own cautionary tales. It may underestimate true clearance or risk of underdosing medications. Sufficient to say, there are a lot of changes that occur in patients in hospice and palliative care. With your medications, it's just important to know your competent to medications, how to account for these in dosing, and we can, but sometimes, again, we have to go the proverbial, let's start low and go slow, because each of these may impact it one way or another. Now, before we move on to some clinical pearls of opioids and how we think about using those in our patients, I want to take a moment to pause and see what questions you have. What can I help to clarify for you? I'm going to open up the chat while I'm waiting for questions to come through. I will tell you when you, I'm sure many of you have taught before, they tell you to wait 10 seconds after asking the question and then moving on. It's pretty awkward to sit here for 10 seconds. So please, if you have questions, ask them. It's actually makes things a little more comfortable. But if you have questions, please ask. I'm happy to help clarify. But hearing none, I will go on to, sorry, some clinical pearls of our opioids, the most common opioids. Now,
Justin,
yeah, go ahead.
There was a question that came up in the chat. If you could speak again to phase 1 and phase 2 glucuronidation,
Yes.
which is more affected in the chronically ill. Thanks.
Yes, I can do that. Sorry about that. Yeah, so phase 1 is our classic CYP interaction. So that's go through, you have an enzymatic pathway, and you have this enzyme that are breaking down and metabolizing medications. So CYP3A4 is the most common, 2D6 there as well, 2C19. So the CYP enzymes, which are made by the liver, are more impacted when you have someone who has either acute or chronic hepatic dysfunction. So and honestly, when we're measuring synthetic function, there are a lot of ways to do that. Probably the best way is through measuring looking at INR. Someone has an elevated INR, that's one of my clues to look elsewhere. I'll start looking at other values, but it makes me wonder that what our acute synthetic function looks like. INR and albumin together give you a fair look for long-term synthetic function of the liver. So phase 2 is glucuronidation. It is impacted, but less so than phase 1. So glucuronidation, there are different pathways through phase 2, but that's the most common people have heard of. So if you're going to choose a medication and metabolic pathway, we want to lean towards choosing phase 2. So the reality is, this bullet point here, what I'm telling you is phase 1 is more impacted. And what I probably could do is, I'll type it on here to help reduce some confusion. So, and I apologize for that, is phase 1 more impacted, phase 2 is preferred, if you're going to think about it, if you have an option. So thank you for that question.
Justin, there's a follow-up question in the chat.
Sure.
I'm speaking for them because I think their audio
Yeah.
might not be working.
Okay.
When these changes are occurring, will we see that as abnormal lab values, like increased liver enzymes, or do we start to see signs of that before it's reflected in labs?
Boy, you're asking some really good questions. It depends upon the medication, and I think depends upon where you're practicing. In my hospice days, where I didn't necessarily have weren't drawing routine labs, I would see it more so with side effects and outcomes. Now, where I work now at Ohio State, this large academic medical center, and the patient sneezes and we get a new set of labs, right? So I think oftentimes in this environment, we're oftentimes catching it with the lab values more so than the clinical symptoms that we're seeing earlier first. Not always. So I think it depends upon the scenario, but I would say the answer is a little bit of both. Sometimes if we're seeing things that aren't making sense, we draw labs and you can see AST, ALT aren't always the best reflection, but I will use that for sure. That's just an impact. That's just they're just telling you that like the liver's been impacted or damaged, whereas INR is a better measure of synthetic function of the liver, and then albumin production is better long-term measurement of synthetic function. So I would say a little bit of both, depending upon the scenario that you're in, for sure. And these are good questions. These are literally, if there's interest and you all can talk, I know Ben sets this up, and if there's interest to do more detailed lectures, let me know. We can come back and circle back and do some of those later as well. Okay. All right. So when we think about our opioids, I have these on classes for you. Don't worry, there's no quizzes coming down the road to you. No structures coming your way, I promise. But why I have these for you are to show you the chemical classes. There are different structures. This is to tell you if you had someone who was theoretically truly allergic to an opioid, you ideally want to choose something from a different structural class. Now, again, I don't know about my colleagues here, some of the fellowship directors and those who've been practicing longer, what your experience has been. But in my, roughly 15 years of experience, I have seen a true morphine allergy twice. True. I've seen it documented a couple of times as well. It is not common, okay? Now, theoretically, if you have someone with a true morphine allergy, or what we kind of extrapolate from data, there's not a lot out there, is the risk is they equated to someone having a penicillin allergy and trying a cephalosporin. So there is some level of cross sensitivity, but it's not 100%. But that being said, you get stuck in a pickle. If someone has a true morphine allergy, ideally you would think about a different structural class. That's why I have it listed here for you. If someone has an intolerance to morphine, by all means, stick with that same class, okay? Also for you, If you're evaluating urine drug screens, and that's a whole probably talk on its own, one I've given umpteen times as well, and you're looking at urine drug screens, please realize that an opiate panel, and please, for the most part, just use the word opioids. Opiate panels specifically are those that are derived from opium or their derivation of, and it only means morphine, hydromorphone, and hydrocodone and codeine. Okay, so it's not going to include oxycodone or oxymorphone in those panels. So just be very careful as you evaluate urine drug screens as well. So morphine, let's start with morphine. Okay, so morphine we think about as our comparator opioid. This is the one that we should be thinking about just in general for our patients. And it's our comparator opioid because it's the most available worldwide. We have the most level 4 evidence with morphine, and that just means we have the most experience with morphine. We have a lot of dosage forms available. We have several different long-acting preparations. We have various different IR preparations, the tablets, the liquids, and a lot of different parenteral forms as well. It can be used IV, sub-Q, intrathecal preparations as well. And year in and year out seems to be the opioid that has the least impact for drug shortages. Okay. So the question is, if it's our theoretical comparator drug or drug of choice, when do I want to be cautious? When should I be thinking a little more about maybe using a different opioid? So what we know with morphine, it goes through phase 2 metabolism with renal excretion. So with phase 2 metabolism, we see different metabolites. We see glucuronidase metabolites. So with that being said, we see morphine 3 glucuronide and morphine 6 glucuronide, amongst other minor pathways. Okay. But the morphine 3 and morphine 6 glucuronide actually is an active metabolite that contributes to the analgesic pathway that we see profile. And so in many ways is considered to be healthy and good. Now, morphine 3 glucuronide is that bad cousin. It's the one that never gets invited to the party because it causes problems, right? Gets rowdy, raucous, and can't handle itself. Okay. So morphine 3 glucuronide in large concentrations, when it builds up, can cause myoclonus, hyperalgesia, allodynia, and neurotoxicity. So that's probably why some of you've already heard morphine is a drug that we tend to be very careful with or try to avoid in patients with renal insufficiency, renal failure at higher doses. Now, what's higher doses? I'll let your fellowship directors set that for you. Typically, I begin to think about 200 or 300 milligrams a day as a threshold for I need to start thinking about elsewhere. It doesn't mean you have to absolutely avoid morphine in renal failure, but you need to be thinking about it very, very carefully. What about your anuric hospice patient who's taking, 5 milligrams of Roxanol once or twice a day, and they're on that dying pathway? Probably going to be okay. But what we want to be aware of is at higher doses or more chronic use and have renal insufficiency, there are probably better options. Being the fact that it's phase 2 metabolism, morphine's a good option when it comes to hepatic impairment. If you are a program that likes to use singular opioid agents for your patients, morphine for long-acting, short-acting, and I think you will see various different thoughts and opinions about that. I would just suggest that you're very careful in your patients when they go home and do counseling about what to do, because I have seen a lot of accidental errors about preparations and folks mixing them up. Because I spend time in our outpatient powder care clinic and they come in, I see more instances of tablets being mixed up. So I am a big fan of, even in a powder care patient who has a really good prognosis, if I'm going to use morphine for both, I use the tablets for long acting and the liquid for short acting. It just eases explanation for your patients. Despite our best education, when you use the same opioid, there's just a lot of confusion that happens, even with our best education. Oxycodone. Oh, oxycodone. Love-hate with oxycodone relationship, right? We've come to find out so much more of oxycodone over the last few years. Okay. I say now, thankfully, oxycodone is on a drug shortage. It's reducing our availability to use it, which for me makes me happy. So with that being said, oxycodone is still in the same class as methadone, as morphine, sorry. It is a good option or consideration those folks who have side effects from morphine. If a patient truly has a little bit of nausea or drowsiness that you can't dose around, oxycodone is a good consideration. It goes through phase 1 metabolism. It goes through CYP3A4 and CYP2D6 quite heavily. So you get active metabolites with oxycodone. So yes, active metabolites with oxycodone. Those metabolites can build up in patients with hepatic impairment. You can see upwards of a 40 to 60% increase in oxycodone accumulation in hepatic impairment. Makes it a little harder to dose around. So it's an okay option in renal excretion because those metabolites aren't toxic per se. So it's better than morphine, but maybe not as good as others. With hepatic impairment, use with caution because concentrations will increase, but we can't predictably say how much. So it's an okay option in renal insufficiency. Maybe those have high dose needs, again, but and there's side effects. I will tell you with a high level of confidence of your oral opioids, oxycodone has the highest level of likability among patients. We know opioids cause different effects other than just decreasing pain, right? They cause some level of relaxation, distraction, and some patients euphoria. All opioids are going to do that unless you're using pure opioid antagonists, right? They all do that through various different mechanisms, primarily dopamine release. But we also know that opioids do that through a kappa effect as well. And oxycodone has our highest level of kappa agonism, which is why patients just tend to like oxycodone so much more than other opioids. And we have studies now showing if that's true. Oxycodone extended release comes in tablets, OxyContin, which is always on and off shortage, and also Xtamza, which is a capsule that can be opened up, has good abuse deterrency, but it's quite expensive. So oxycodone is a good option, but again, love-hate relationship with oxycodone.
Hey, Jason.
Hydromorphone. Yes, go ahead. Question. Yeah,
Hey.
Ben.
Hey, thanks for being here, and I'm sorry I was late.
Yeah, no worries.
So there were a couple questions in the chat.
Okay.
The first one was, I think, about just the overall classes of opioids.
Yeah.
If I think that's 2 slides back.
Yeah.
Just thinking about rotation.
Yeah.
That correct me if I'm wrong, but morphine and oxycodone are natural and semi-synthetic, technically.
Yeah. So morphine and codeine, we kind of consider natural. Morphine is
right. That's right.
Yeah. And then like hydromorphone, hydrocodone, oxycodone, and oxymorphone are all semi-synthetic.
So
Yes.
when you're thinking about a rotation, should you think about rotating between these groups? For example, morphine to methadone or morphine to fentanyl?
Yes.
Or should you think about rotating between natural, semi-synthetic, and synthetic?
I think, yes, I think in general, we probably could put a little chasm in there, like a little dotted line between codeine and hydromorphone. And that would probably be a good way to think through that. Yeah, I think the reason why you're rotating ultimately would be how I would help answer that question. If it's for a true allergy perspective, true allergies, which we know is rare, I would go to a different class just to be cautious. If it's due to tolerance, I would go from a natural occurring to semi-synthetic or fully synthetic either way. Yes, and let other reasons drive that selection. But you can comfortably switch from morphine to a semi-synthetic due just to intolerance.
Right.
Comfortably switch. Yes.
Okay.
Thank you for that clarification. Yeah.
And there was a question about chronic pain patients with allodynia.
Yes.
Do you have a sense of how long it takes to occur in palliative patients?
Yeah. Great. So we're talking about hyperalgesia, and So I think hyperalgesia is probably what we're going to see a little more before we'll see fulminant allodynia. That's a great question. And we're learning so much more about that over the last 10 years. It's really shaping how we're treating chronic pain. What we can appreciate is hyperalgesia does probably occur pretty quickly, more so with our natural opioids first, followed by synthetic opioids, lastly fully synthetic opioids. How hyperalgesia occurs is multifactorial. Okay, multifactorial. One pathway that we know to recognize that causes that from opioid exposure are metabolites. Okay, and those with known toxic metabolites, you're likely to see it a little earlier on. Morphine and hydromorphone, which is what we're going to get to next with hydromorphone. So all opioids can cause hyperalgesia. It can occur pretty quickly. There's some really neat data coming from the acute post-op pain world that shows us that subacute hyperalgesia happens pretty quickly. I mean, within doses of opioids. But I would say subacute clinically because I'm not sure it's affecting the clinical outcome, but they're seeing some of that. But I would say clinically relevant hyperalgesia would depend upon the overall dose exposure. So high dose exposure, you might see that. You can see that within days to weeks if someone has been escalated on a high dose morphine or hydromorphone due to pain. You might see that pretty quickly. Otherwise, if you're gradually increasing these medications, it can take weeks to months to see some of that. You're going to see it a little more quickly with, again, morphine, hydromorphone due to metabolites than you will, well, thankfully we're not using meperidine, but meperidine as well would fit there than other medications. Again, the hyperalgesia and opioid neurotoxicity is another great hour-long talk. If there's interest, we can circle back around, but that's a nice summary of that kind of 45-minute to 50-minute talk. So again, what wonderful questions you all are asking. I love these questions.
There's two more in the chat too.
Okay, yeah, bring them up. Yeah,
all right.
absolutely.
The Bupe question.
Yes.
What is the chemical class of a partial agonist?
Excellent. And you know what? I meant to update this slide. As most of you know, well, many of you know, like it is unequivocally the best opioid ever. No, right. But there are a lot of reasons to like buprenorphine. It is from the medications that we have available in the United States, it's most similar to oxycodone. So it's a semi-synthetic phenanthrin opioid. It originally was derived from thebaine, which is not available. And some of my colleagues who mentioned me many years ago had experience with that years ago. But oxycodone, surprisingly, but with that, there are a few key structural differences that make it a kappa antagonist versus a full kappa agonist. But yeah, so bupe would kind of fit there. Yeah.
Great question. And the other one was a little bit of clarification on the morphine 3 glucuronide.
Yes.
So how do we get or avoid it? And the second part of that is liquid morphine more expensive?
Okay, good. So morphine 3 glucuronide is just a normal metabolite that will occur from, so there, and when we say metabolite, I think hopefully you appreciate we're talking major pathways. When morphine is glucuronidate, goes through first pass metabolism, you see a large pathway percentage of M3G and M6G. So that's just natural. There are other minor metabolites that you will see as well. At normal standard doses, something with normal renal function, the body can clear M3G out at a readily basis. That's not a problem, not an issue. So what becomes problematic is when it can't excrete M3G as fast as it is being produced. So in essence, how much is coming in and how much is going out. So you can have M3G build up in an instance where your outward pump per se, the kidneys and urine, can't pump it out fast enough. The other pathway is you're giving such high doses that a normal, even though your pump is working normally, it's just being overloaded with drug, in a very bad analogy. So we can avoid M3G in scenarios where we know we're at high risk. So super high doses, so we rotate before we see a problem, or in somebody who's using more than small sporadic doses and who has renal insufficiency, then we avoid that, just avoid the problematic M3G. What we know, and again, the fellowship directors here, please jump in. What we're learning and seeing is we're seeing insidious signs of this before. Changes in mentation, confusion, delirium, subacute myoclonus, and subacute hyperalgesia. We're usually seeing that be the signs before we get to fulminant opioid-induced toxicity. When you see it, you'll see it the first times. You will not mistake opioid-induced neurotoxicity, and hopefully you don't see a lot, but it's pretty easy to see when it does happen. The other opioid for which that is a concern, and this is something that was mistaught for years and years and years, is hydromorphone. Hydromorphone is a semisynthetic opioid that mirrors morphine in metabolism. Okay, so hydromorphone goes through phase 2 metabolism. So that's a good option for hepatic impairment. Yes, good option for hepatic impairment because less impact than other opioids. Though it is metabolized to H3G and H6G, H3G is neurotoxic, albeit less H3G is formed per dose than M3G when you look at morphine. So hydromorphone is, in some ways, a marginally better option than morphine and renal impairment. And this has been mistaught for years and years and years. And I have had some beautiful debates with some very lovely people about this topic on many occasions. And I have a lot of articles for those who don't believe me and can read them at your own discretion. Okay. Needless to say, again, I think it's a slightly better option than morphine. And at low doses and frequent doses, it's not going to be problematic. But at high doses, we have to worry about H3G building up. Okay. Morphine is a great option, or hydromorphone is a good option. Those with high dose needs, particularly in your hospice patients who are on sub-Q administration, you can give such small doses of, and that's great. And those who have side effects. Okay. My guess is you're not going to see the long-acting formulation very often, called Exalgo. It's convenient. That's once a day. That's great. It's also expensive. And that reminds me, I forgot one of the questions earlier about morphine cost in liquid. The morphine Roxanol preparation, which is 100 milligrams per 5, or we classically think 20 per 1, is one of the least expensive products that we can think about for our patients. Okay. Contrast that to things like Exalgo, long-acting hydromorphone, expensive, expensive, expensive. Okay. Hydrocodone. This drug, oh boy, had you been here 15 years ago, oh, what a different lecture, right? Thankfully, we're not seeing a lot of hydrocodone anymore. There's again a bit of a misnomer that hydrocodone is a prodrug. Again, a prodrug means no effect, has to be metabolized to an active drug. Hydrocodone is a weak mu agonist, okay? So it is not a prodrug, it's not a very strong opioid. It is metabolized through phasal metabolism to many different agents, one of which, a minor pathway, is hydromorphone, Dilaudid. So hydrocodone's response is variable in patients due to its metabolism. So patients you might see a variable response in patients given how much hydromorphone they metabolize to, okay? It's often combined with acetaminophen, which limits our dosing when we're monitored for fever or overall dose. There are single agents available for long acting, just not very easy to find and can be expensive. If you're looking for a cough suppressant in patients who need an opioid and a cough suppressant, hydrocodone is a better option than codeine, and we'll see why here in just a little bit. Oxymorphone, not very common anymore. It's here listed for you. Brand name is Opana. I think it has advantages. It does go through phase 2 metabolism, so it's better in patients who have hepatic impairment. Remember, oxymorphone is an active metabolite of oxycodone. Oxycodone, again, goes through CYP2D6 and 3A4. Oxymorphone is a metabolite of the 2D6 pathway, okay? So oxymorphone is 3 times more potent. I use 3 times more potent There are different opioid conversion cards out there. I tend to like the original one more so than round 2, but that's a different debate for a different day. But oxymorphone is roughly 3 times more potent than oral morphine. It is less commonly used. There's a whole big story of when the opioid crisis really hit, and we became aware of it, of why it's not as readily available. Okay, but realize it's there for you. We can talk more if you see much of that. Codeine, oh codeine, oh codeine. Okay, just have a really good reason to use codeine. Okay, codeine is a naturally occurring opiate. It has some of the highest incidence of adverse effects, what I say everyday adverse effects, causes a high level of constipation and nausea, vomiting. In fact, it is the most constipating and nauseating of all of our opioids. So when I have a patient who has severe diarrhea, non-responsive to anything else, I give them codeine. Okay. Codeine is a prodrug. On its own has very little to no effect at the mu receptor. So I want you to hear that. Codeine on its own has very little to no effect at the mu receptor. It is metabolized to morphine. Okay. So roughly 1 in 8 patients are a poor metabolizer or lack the enzyme to metabolize from codeine to morphine, meaning 1 in 8 patients gets a whole lot of nothing. You have a big spectrum of that activity of that enzymatic pathway. So codeine being metabolized to morphine is a fair bit unpredictable. Those of you who have practiced in OB at all have maybe seen this, right? There are stories left and right of unfortunate cases of mothers have been breastfeeding and just unexpected changes and fluctuations in morphine concentrations and quite tragic outcomes. Again, it's sure it's available in a lot of different preparations. People hear about it for cough. We can talk about opioids for non-pain related conditions in the future if you so choose. I have lectures prepared for that as well, and how opioids help with cough. Okay, but sufficient to say hydrocodone is just fine for cough over codeine. Moving on to our phenylpiperine derivatives, meperidine, the original brand name is Demerol, okay? But so you remember, we call it Demerol or Damodol. That's its real brand name. Sufficient to say that's why we don't use it. So fentanyl. This is another one where, again, a very different lecture from years ago. And if you are going to be considering fentanyl in your patients, which it's a great opioid, it's a fully synthetic opioid, okay, which makes it nice. This now, I have a very different approach to patients than I did 5 years ago. The word fentanyl often introduces a very visceral reaction in patients, as you can imagine. Didn't have to worry about this 5 years ago. But now I say, hey, we have an opioid we think is really going to help you. This opioid's been around for over 25 more years. We have a long history of using this medication for pain. It's effective and in fact has sometimes our patients do a little better tolerability, have less side effects than with other opioids. The name's kind of scary. And so when we go through it and we talk about it, I want to take a moment and pause. And I want to hear your reactions. I want to hear your thoughts because you're going to most likely have heard about this before. That medication is called fentanyl. Now, you all, again, our fellowship directors are trained in communication strategies so much better than what I am. And you're probably even more eloquent than I am in that. But it's so important to lead in that when we talk about fentanyl therapy patients, because it's quite scary to them, right? They're going to equate fentanyl with overdose and deaths in the Mexican cartel, right? And so we got to kind of lead in that way and offer those moments to pause and reflect and hear their concerns. Fentanyl comes in a lot of different dosage forms. It's heavily metabolized by CYP3A4, thankfully to non-active metabolite. So if it's 3A4, you get these NOR pathways, so norfentanyl. So that's beautiful. No active metabolites. That's really why it's a good agent because you have no active metabolites, but it is heavily metabolized. So if you're using fentanyl in a patient with hepatic dysfunction, how you dose it's very different between acute episodic IV injection versus continuous infusion. Very different dosing strategies because of how it equilibrates into the plasma from the CNS. Okay. That being said, it's a great drug in patients who have renal impairment problems because there's no active metabolites. It's very lipophilic. It crosses lots of different membranes. I think about its onset and duration differently, but it's like a light switch. It's on and it's off. A lot of different formulations. You have these transmucosal products that are available for you. This is like the Attique. We call it lollipop. That's not really a good term for it. We call it lollipop. The buccal lozenges. Again, just here for you. They're not common. They're a niche population. Just beware using them on label. The patch, right, is good for chronic, stabilized, well-known trajectory pain. Okay, patch isn't great when you have changing pain, slow onset. It can be difficult to dose and titrate. Patch has a place in hospice and palliative care for sure. Just make sure. Again, we're a little less concerned about the cachexia than we were years ago due to what we talked about very early on. It's not a contraindication. We're learning more, but still we got to be aware of that. Moving on to methadone. Oh, when you hear Lynn McPherson talk, and I'm sure at some point in time you will, she's the queen of palliative care pharmacist. I affectionately, about her every time I see her. She's a wonderful, wonderful pharmacist, and this is her favorite drug, and she'll tell you all about it. Methadone does deserve its own lecture for sure. So the good, the bad, and the ugly. Okay, very quickly wrapped up for you. Goes through phase 1 metabolism, though methadone is a very promiscuous drug in this way, in a good way. Goes through very different pathways. So its metabolism is shared. So you see its impact in hepatic impairment a little less than other drugs because it has different pathways it goes to. It's not necessarily the best option, but it's an okay option in hepatic impairment. Its excretion is different pathways, primarily through the feces. So it is a good option in renal impairment. So it's an okay option in hepatic impairment and an okay option in renal impairment. So the reason why we like methadone. Methadone has multiple pathways that make it an effective drug. Just like morphine, hydromorphone, fentanyl, it is a mu agonist. It also inhibits reuptake of serotonin or norepinephrine, neuropathic pain. It also is an N-methyl D-aspartate receptor antagonist, and you'll talk a lot more about ketamine moving forward. That's how ketamine works. It's a weak NMDA receptor antagonist. That helps out with things like hyperalgesia and allodynia. Most people will misinterpret that meaning that's for neuropathic pain. Sure, it can be, but it's also for nociceptive pain when hyperalgesia is causing that. So it has 3 mechanisms. It's a wonderful, wonderful, wonderfully effective pain medication. That's the good. The bad, a lot of drug interactions. We have to worry about QT prolongation. Has a very long elimination half-life that's variable in all patients. Has phase 1, phase 2, dosing considerations. It's hard to dose. Oh, how we love methadone. But you got to be very careful with dosing. There's a lot of different dosage conversions to and from other opioids. This is one where when you are rounding, I think it's really wise when you're rounding as a team to say, take a moment, come up with your dose, and no one blurt it out. Everyone should write it down and then talk about it together. This is one where even us, those who have a lot of experience, sometimes we make mistakes. So it's good to come up with our own dosages and talk about them together. Okay. Why might we use methadone? Neuropathic pain, renal sufficiency, a lot of good reasons. Okay, again, methadone deserves its own hour. Buprenorphine, buprenorphine deserves its own day. Now, all kidding aside, it deserves its own lecture as well. It is pharmacologically categorized as a partial mu agonist. Please, please, please realize at most dosage conversions, it's 30 to 100 times stronger than morphine. It provides sufficient pain relief at most doses. We don't have to worry about this fact that it's a partial agonist and a high affinity opioid until you get to very high doses, above 16 milligrams a day. And even at that, we're getting a little more controversial considerations. Wonderful pain medicine, less side effects, less euphoria, less craving, good option of renal impairment, good option of hepatic impairment, It's a really effective option for our patients. Just again, deserves its own hours. It has its own pitfalls as well. Tramadol, again, people really like to bash on tramadol. Boy, oh boy, does tramadol have a bad rap. It has its place. It is an absolute niche, small market. It is a small, small market niche. Be careful of how it's used. It's a prodrug, but there are times when it's the right drug. It's just a small market drug. Okay. Apologize for rushing through that. You got about 8 hours worth of fun topics in 15 minutes. Want to take pause, and I do urge you, if you get stuck in a really bad pickle with a symptom, my email is here. I'm more than happy to help go through that if you don't have pharmacy support at your relative institution.
Justin, thank you so much for being here.
Yeah, my pleasure.
Leading off the boot camp, I think we're hitting the pharmacy a little bit harder for folks to really start thinking about the medications and the active symptom management we do instead of just the goals of care. Of course, both are important. You had a couple more questions in here.
Okay.
One question was, what do you recommend for pain and dyspnea for a patient on hospice for end-stage cirrhosis with hepatorenal syndrome?
Oh boy, oh, man, they're just coming at us full force, aren't they, today?
That's me. They're excited.
They're excited, yeah. So hepatorenal syndrome, hospice, pain dyspnea. I would really want to know a little more about the renal function. Are they anuric? What's the trajectory? You know, that the best we can prognosticate. You know, we're looking at days to weeks, weeks to months. I will tell you here, more often than not, I'm probably leaning a little towards morphine just based upon experience, unless we're climbing towards higher doses. If we're getting above 100 milligrams a day, now we have a different conversation about what's available on our formulary, what's practically available where we are, and going on from there. If they're getting a little bit of neurotoxic, you buy some time with a rotation hydromorphone again. I mean, there really isn't a great answer here, and this is not me punting. I love me some fentanyl if you can get it, but that's a hard way to do, especially on the home care side. Those at-teak preparations can be hard to get, hard to use, and quite expensive. But if you are going to be at those doses that you're using for dyspnea and the pain, and they're not climbing too awful high, I consider morphine. If you're getting the moderate doses, I'll try to use the fentanyl as a long-acting and morphine as a backup. Recognizing for dyspnea, there is kind of a cap effect that we see for dyspnea. Ben, I'd love to hear how you'd answer this question.
I mean, hepatorenal syndrome has a median life expectancy on the order of weeks.
Yep.
So I think that it's not. I guess what I get most concerned about with morphine and renal failure is the morphine 3 glucuronide, and I think about the patient with. I was just talking with the fellows in my program about like a patient with. Guys, what was I saying? With like multiple myeloma.
Oh yeah, sure,
Like
sure.
that, and
Yeah,
burned
yeah.
out, and then they could live for weeks with the renal failure, but I would still, that's kind of a layup to avoid morphine analogs. But for them, if they're having dyspnea at the end of life, and it's a short time, I would start with morphine and then rotate if we run into a problem.
Yep. Yeah, I think so. I think you're gonna have a little more of runway with hydromorphone than morphine. You're right. If you've got somebody who's been chronically ill in that situation, you're right, the prognosis goes beyond that median survival. You oftentimes you'll find you're just kind of going through and rotating as you can, but the prognosis usually in some ways helps you here. That's been my experience.
Great. Thank you, Justin, for your
Yeah.
time. There were a couple more questions. If you guys want to email Justin, I know that he is an amazing, very accomplished palliative pharmacist, and someone I've been very lucky to work with on a couple projects. So thank you for being here.
Yeah, my pleasure. Yeah, send them my way. Thanks.
All right. So we have one more lecture for this first 2-hour block from Dr. Alex Leigh. I've heard it's a chilly day in Louisiana.
It is. It is. It's always nice and cool here in the summer. And I happen to be outside because I'm in a city nearby where my daughter's doing volleyball camp. And this is a place with Wi-Fi. So I hope y'all can hear me.
Sounds great.
All right.
Dr. Leigh, just Leigh, right? Sorry. Leigh?
All right. Leigh.
Just sent
Like-
an email as well. So if you wanted to pull that up and potentially download your conversion table, this might be a good time to do it.
All right, everybody. Let me see how I can get this to do a slideshow. All right, does that look like a slideshow to y'all?
Perfect.
Awesome. Welcome, everyone. My name is Alexandra Leigh. I've been doing this work since I graduated fellowship in 2010, and I've always worked at a VA. And it's my great pleasure to do this lecture for the second time. It's a hard lecture to do by PowerPoint. Conversions really need to be done, in my opinion, one-on-one with a whiteboard. So I hope you get a whole lot more conversion lectures in the next few months, because this is the fun of it. This is the stuff you sit around with your friends and you take out your chalk and you go to town and you see if everyone agrees, and it's really a lot of fun, and it's amazing how intimidating this is to other physicians. So getting good at this will make you feel like palliative care is more than just spending more time talking to people. It's going to give you a really special skill set that other people will love, that you know. So here's the kind of things we're going to be talking about today. I'm not going to read that, but just take a gander. And I really want to credit Mary Lynn McPherson, who is a goddess and a pharmacist, and she has written this book, and I hope that you will do a lemonade stand this weekend so that you can afford to buy this book, which is available on Amazon. We really need to make sure Jeff Bezos has more time on his yacht. So buy this on Amazon this weekend, and you won't be sad, and make it a point to read a chapter every 2 weeks, and you'll be through it in the first 6 to 8 weeks, and you'll be a better doctor for it. Okay, so we're going to go really basic here, and I know you just had pharm on this, so I probably am repeating myself. But what is an opioid? It's important to know what an opioid is, so you know what it is. Okay, an opioid is a drug that's primary mechanism of action is on the mu receptor. Okay, now there's other drugs that act on the mu receptor that are not opioids. I think of ketamine. Ketamine's primary mechanism of action is on NMDA, and that's why it's not an opioid. So if its primary mechanism of action is on mu, at least as far as we know with the science we have now, we call it an opioid. Okay, all opioid receptors are G protein coupled receptors. They're located both peripherally and centrally within neural and non-neural tissue. So if I rub morphine on a lesion inside of my mucosa, that's going to hit more potentially mu receptors on that mucosa. Opioids have action on the mu receptor in varying amounts. They often act on other receptors too, kappa, delta, zeta, nociceptin. And so I think in the coming years, we're really going to understand this a little bit better than we do now. But just recognize that some of the differences your patients might perceive in opioids are because of these variations in actions on other receptors. And when we look even at the science behind which opioids have been shown to be standard of care for, say, shortness of breath, this might be why some of the science says that morphine is better for shortness of breath than, say, oxycodone. Might have to do not with its mu activity, but with maybe something happening at kappa that makes oxy not so good. I wouldn't memorize this table. You don't need to keep this table, but just recognize that there are numerous receptors that opioids act on. Primarily mu is what we're after for pain benefit, and that drugs like hydrocodone, oxycodone, hydromorphone are all going to act differently on these different receptors. A word about language. Opioids and opiates are not the same thing. And now that you're a professional, just like you would never say advanced directive, you should never use opiates when you mean opioids. Opioids is the big category of drugs. Big category of drugs that works primarily on the mu receptor. Opiates are a smaller group within opioids that are derived from the chemical that is in the poppy plant. Okay, so we really don't use the term opiates a lot because it's a really narrow term. We want to use the term opioids because that includes both opiates and synthetic opioids. Tramadol, if it acts primarily on the mu receptor, it's an opioid. So even though it's synthetic, like fentanyl, it's still an opioid, but not an opiate. Okay, so just a word on language. A word on genetic variation. Back in my day when patients said, you know, doc, I feel like the morphine doesn't really work. It's just, I only get benefit from the oxy. We used to call them drug addicts. But these days we know that we were wrong and we were biased and that actually there is genetic variation in how people are going to respond to different opioids. So don't be an idiot like me and recognize that sometimes people are going to have different effects from the opioids irrespective of the conversion. Okay? So even if you convert perfectly, you may switch someone to a new drug and it may just not work for them. Okay? Similarly, some people will have more side effects with certain opioids than they will for others in ways that we don't really clearly understand yet. Okay, here's a chat box I see. I'm not. Dr. Al. Oh, Marcia. Marcia's talking me up. Thank you. Thank you, Marcia. You're so sweet. Okay, let's start with the opioid naive patient. Okay, hold on. What did I do? All right. I know it's a lot of text. Bear with me. Miss Robichaux is a 66-year-old female with newly diagnosed recurrent metastatic breast cancer. Her performance status is an ECOG of 2. That means she's still able to get up and down pretty well, though with some heavy symptom burden. And she's seen in the hospital after admission for port placement for pain. She's got pain in her left hip and low back, and it affects her ability to enjoy her day. She's status post radiation to these sites with mild improvement. An MRI has been done recently, and there is no need for neurosurgical intervention or radiation for an unstable spine. On physical exam, she has no lower extremity weakness, good kidney function. She's taken a lot of Advil every day, and she finished a prescription for Percocet 5 from the radiation doctor about 2 weeks ago. How do you begin? Okay, here's A. Given her pain is around the clock, start morphine sustained action at the lowest dose possible. I like it. Or is it B? Increase the ibuprofen. You have room to go. You could do 800 and add steroids, and steroids are so good for bone pain. Or C, start Percocet 5, oxycodone with Tylenol, Q4 hours PRN for pain. All right, so everybody think about your answer. All right, just give me a raise of hand for A. Give me a raise of hand for B. Give me a raise of hand for C. Okay. So the answer is C. So remember that for cancer-related pain, opioids are still the standard of care. Okay, and we really don't like for people to be on ibuprofen for the last 1.5 years of their life at high doses. And oftentimes when people are going to initiate chemotherapy, especially in these days, steroids for the rest of their life are not a good option. And steroids lifelong, when you have long months or years left, often run into real side effect problems. So we don't use opioids because we love them. We use them because they're all we got. And so we're going to start a short-acting opioid around the clock. Okay, this is my whip crack. Whip crack number 1. Opioid naive patients get opioid naive starting doses. Well, wait, you said she was on Percocet 2 weeks ago. Unless you are on opioids daily, okay? Typically, you are an opioid naive patient, and we're going to talk more about what else makes an opioid naive patient. This is whip crack number 2. opioid naive patients never in this country start with long actings. Okay. In our country, we don't make long actings in low enough doses to start opioid naive patients on them. Back in my day, when I was trained, we thought, oh, if pain's long acting, we want to give long actings. And we put people on just long actings to start. And we killed people. We know that long actings are much, 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 much more dangerous than short acting medicines. Okay. And that's why we never start an opioid naive patient on a long acting in this country, asterisks, with the exception of maybe a Butrans patch or methadone. Okay. Never a fentanyl patch on an opioid naive patient. Never. I see this done in hospital medicine all the time. Do not do it. Okay. Any questions there? Okay, great. I sent this table to you. And on the little printout I sent you, it has these nice opioid naive starting doses. Okay, we don't really use codeine, so it's just there for completion's sake. But these are nice opioid naive starting doses. Morphine, 7.5 milligrams, that would be, or 5 milligrams, that's half of a 15 milligram pill, which sadly is the smallest pill we have. I will say as I've gotten older, I'm using this less as a starting dose because I've seen people have to half these morphines and it's just sand. But that is a starting dose for all. Morphine, hydromorphone, 1 milligram. Some people might use 2 in a robust person. Oxy, 2.5 to 5. I think most of us would go to 5. Hydrocodone, 5. Tramadol, 25. Codeine, 15. And then we have some IV intravenous starting doses. Please notice for hydromorphone, it's not 1 milligram. It's not 1 milligram. It's 0.2 milligrams. Okay, so dilaudid starting dose is not 1 milligram. There's a reason people who are drug seeking like dilaudid is because you've been using very high doses. Okay, so remember 0.2 milligrams on that one. Okay, I have a little star there on morphine. If inpatient, consider 5 milligrams of oral liquid. However, I do not send most people who are opioid naive and not really well known to me and established in clinic, who I love and have a very close relationship, home with oral liquid unless they're on hospice care, because a lot of oral liquids are come in very concentrated formulas. And if you took a swig, you could get 100 milligrams in one little swig, which is how I take my liquid medicines. I don't know about you. Okay. So you start Miss Robichaux on the Percocet 5, which is oxycodone, and the next day her pain is a 5 out of 10. You double click on the medicine in your chart and you see that she took 2 doses of that medicine and she found it helped a little, but not as much as she hoped. Her pain remains chronic around the clock. What do? A, you give up, time for a beer. B, increase the oxy to 10. Clearly the 5 wasn't strong enough. Or you schedule the oxy at the same dose, Q6, and reassess tomorrow. Okay, so everybody choose your answer. Is it A, it's always time for a beer, B, increase to 10, or C, schedule at Q6 and reassess tomorrow? Okay. For me, it's C, and let me tell you why. The magic and dangers of around-the-clock short actings. So we can make a short-acting pill become a long-acting by dosing it around the clock. Scheduling the drug or taking it regularly also increases the plasma levels of the drugs and not a little. So this is a drawing that I did looking at the plasma levels and the time on of taking a medicine. So if we look at, I don't know if you can see my mouse, but if we look at time 0, let's say we take a Percocet 5, it's going to increase until it reaches peak. Let's say that's, 30 to 60 minutes. And then we're going to have half of the medicine gone as it washes out with our liver and kidneys. That's our half-life. And then the medicine will continue to wash out over the next few hours. And then when we take another dose, it'll happen again and we'll have this washout. When we start taking something scheduled, we reach a steady state after 4 to 5 half-lives. And that achieve something very different than taking something PRN. If we have easy access to the drug, so maybe we're at home and we can take our medicine when we need it, we begin to reach a higher plasma level than we would with one dose. And it can be up to twice as high, depending on your renal function and your liver function. When you reach steady state with small doses scheduled versus one dose PRN. Does that make sense to people? At a hospital, it's really hard for patients to get PRN medicines. They have to bother the nurse. The nurse is busy. The nurse was short with them and they don't want to ask the nurse for pain. And so when we schedule something, it certainly can make it a lot easier for the patient to receive it. We also can add little criteria that say hold if sleeping, hold if, respiration's less than 10. And this can help our patients get their medicine and also achieve a steady state. Any questions about this? Likewise, if we just took her to 10 milligrams, let's say this is a 5, if we just gave her 10, we would reach a higher plasma concentration and the washout would be longer. But that medicine would not still be around the clock the way it would if we made it Q6. Okay, I see we got questions here. Okay, it's in the same. Do we get access to these slides? Sky, you do. There you go. Okay, moving on. This is also explained in Mary Lynn McPherson's book. And I really think that this is a key concept to what is going to make you better at this than your hospitalist neighbor, okay? You really need to understand that when a patient is at home and can take something frequently, they're going to achieve a steady state of sorts. And that's really going to increase the effectiveness of the same dose of a medicine that they were getting little effect from in the hospital. And so for me, before I would increase to Oxy 10, I would make the Oxy 5 Q6 offer may refuse, which would be scheduled. I would make another 5 available PRN. And then I wouldn't worry about scheduling it when they went home because they would achieve steady state on their own, probably by doing it their own way. Okay, this is just an aside. The National Comprehensive Cancer Network, the NCCN, this is, if you ever go to Tumor Board and you see them with a humongous book, that's the NCCN guidelines for how to treat cancer. Right, it's like oncology. No offense to my wonderful oncology friends, but it's a lot of like opening this book and then seeing, okay, what cancer does my loved one have, and then my patient have, and then following the guidelines, and so they really are what standardize oncology care around the country. And for acute severe pain in the opioid naive patient, they recommend 2 to 5 milligrams of IV morphine at minute 0. And then a reassessment at 15 minutes, and then if insufficient, increased dose by 50 to 100%. And now this is for acute pain and not really what we're talking about with chronic pain, but this isn't a bad idea. I would argue 15 minutes is a little bit too soon, maybe 20 minutes, because we don't really hit peak effect of the first dose until 20. But I like it if insufficient, increased dose by 50 to 100%. And you're going to see this a lot in palliative care. One of the pearls or the whip cracks of palliative care is that if a person's medicine dose has not been effective, and let's say we've already made sure that they're getting it frequently enough, so they're getting it already 4 or 6 times a day if it's a short acting, we increase doses by 50 to 100%. Maybe with a really frail older person in clinic who lives alone, I might do 30%. But we do a meaningful dose increase when pain is insufficient. So with that Miss Robichaux, she got 2 doses in 24 hours. By giving her 4 doses, we really increased her pain medicine by 100%. Okay. If someone had a broken femur and we're coming in with a pathological femur fracture and we gave them morphine 2 and it wasn't effective, we really could then give them morphine 4 to try to get them under control, 100% increase. We don't increase by 5%. We don't increase by 7%. Okay, so that kind of tiny little like grains of sand dose increase is not what we do. Okay, maybe someone will disagree with me and I would love to hear it. Okay, so I'm going to move on from that. That's acute severe pain. Let's go on to opioid conversions. Miss Robichaux, our breast cancer patient, returns to clinic 3 months later. She had been taking the oxycodone 5, initially PRN, about 3 to 4 times a day for a few months, but has increased over the last 2 months to 6 times a day, pretty much every 4 hours. She even has to wake up at 2 a.m. for a pill. Her pain is now a 3 out of 5, which is kind of her goal, to be around a 3. But she sometimes feels the medicine is not working as well as it used to and wishes she could get a bit more relief. And she probably also would love to sleep a little bit through the night. Scans done 3 weeks ago show that her cancer is not spread. So we don't really have signs that she should have new pain based on her cancer. So what is happening here and now? And you can type it into the chat box. What is this phenomenon that happens when patients are on opioids for some time? What do we call this? What do we call this phenomenon? Kind of like if I drink a beer every day for a year, that beer might not feel quite the same. Tolerance. So tolerance is it's not a sign of drug abuse. It's the expected pattern of a person not getting the same amount of relief from the same opioid dose, right? Not right. So what we're going to see is that those medicines are not going to work as well after a time, even if a person's disease is stable. Okay. And this is to be expected. All right. So how do we treat it? What's best now? Increase it to Q3. We can go Q3, maybe like the half-life of a short-acting opioid pill is typically 3 to 4 hours. So maybe we'll go Q3, and then when she can have 8 a day, and that'll be better. There's one option. B, we can rotate to a new opioid. She has developed tolerance. C, start a long-acting. Her pain is around the clock. Or D, increase the oxycodone to 10. Oh, there's a lot of, there's a lot of good options here. And a lot of providers would choose a lot of these and do them for different reasons. What did I say was the right answer? Let's see. Oh, I liked all of them. So increase to Q3. I'm embarrassed to say I have a patient on Percocet Q3 who's been on it for years because he absolutely refuses to rotate. And he can't do a long acting. He just, he takes it like a PRN. So embarrassingly, some of them, some patients, sometimes you'll break your own rules and you won't be proud of yourself. Rotate to a new opioid. She has developed tolerance. This is an elegant answer, probably the best one. Start morphine long acting. Her pain is around the clock. So let's think about this. She's taking 5 doses of the oxycodone 5. 6 doses a day. So that would be 6 times 5 milligrams. That's, 30 milligrams of oxy. So that's an OME of, that's 1.5 times the strength of morphine, about 45. And she's outpatient. Probably not my favorite answer right now. Or D, increase to oxy 10. So certainly we can stick with the same drug and just go higher. We do this a lot of times. There's nothing wrong with this. You will increase the side effects that you experience with opioids, including constipation, which is dose dependent. But that's certainly an option. Just because a person's tolerant doesn't mean you can't increase doses. All right, let's talk about oral morphine equivalents. Is this new to y'all, or have you heard about oral morphine equivalents? So OMEs are oral morphine equivalents. It's habit in palliative care to, whenever we think about changing doses, starting long actings, moving to a new opioid, to put everything into the conversion as if that drug were oral morphine, okay? It's also called MEDD, or morphine equivalent daily dose. So let's start by calculating Miss Robichaux's OME. So she's on oxycodone 5 and she takes it Q4. So when we do something every 4 hours, there's 6 doses in a day. And we really asked her, we just didn't read what her pill bottle says. We actually asked her, how often are you taking this? Q4, but you say you're taking it Q4. And are you really taking 6 a day? And she's like, yes, I'm taking 6 a day. But you always want to ask, because people will say, I'm taking it as prescribed. And you'll say, okay, well, that means 6 a day. And they'll say, no, I mean like 2 or 3. Okay. And that's 100% difference in that OME. So you really got to ask your patient, ask their partner. So that's 30 of oxy, morphine, and hydrocodone are not equipotent. Oxy is not, oh, what I wrote this wrong. I'm sorry. This should say morphine and oxycodone are not equipotent. Oxy is 1.5 times stronger. So the OMEs here are 45. Okay. Let's look at if you need to do does everyone understand that? Is anyone struggling with that? With how to do that? We're going to do another one using cross multiplication soon. Okay, that will help. I just did that in my head. If oxy is 1.5 times stronger, then I'm going to do oxy 30 times 1.5 and I'm going to get 45. Okay. All right. Why are we not starting her on a long acting? Why is that not my first choice, especially in a patient in clinic? Do not start patients on long actings until their OMEs are 40 to 60 milligrams over many, many days in a row. In a patient whose pain is stable and not decreasing. So never in a post-op patient whose pain is going to be improving. Now you're saying, well, she's 45. Yeah, she's 45, but that's on the tail end of that. That's on the, and she's outpatient. Maybe let's say she lives alone. I'm not starting a long acting on a 40 in a patient who lives alone in clinic. Some people would, especially because she has good pain control. Okay. But this could not be more important. All right. So when we talk about who is opioid naive and who is tolerant, opioid naive patients are those who have an MEDD or an OME of less than 40 a day. Opioid tolerant patients are 40 to 60 for many, many days, preferably a week or more in a situation where pain is not improving. Got to know this. Okay. So we don't, and the reason you have to know this is because when I was training, we didn't do this. We didn't have these definitions. We just did whatever we wanted. And you know what we did? We killed people. And so they made all of us, DEA required it, all of us do all of this training in order to keep our licenses where we had to learn this stuff because long actings kill people. Okay. Short actings are much safer than long actings. So when we start long actings again, I know I'm belaboring this point. You got to have an MEDD of 40 to 60 over many days in a patient with stable or worsening pain. Any questions about that? Okay. Okay, we talked about that. In outpatients in particular, and with elderly patients, you should use caution and wait until you're closer to 60 milligrams of OME to start long acting. So that's my personal opinion. So I don't have evidence to support that, but that's my personal experience because I have hurt patients. I've started patients on fentanyl patches and they've broken their arms and they've not woken up for 2 days and all of these things that I've done to people that really make me follow these guidelines. All right, let's talk about rotating opioids. Why do we rotate? We rotate opioids because there's been a change in the status of the patient, because tolerance has developed, toxicity has developed, because of cost. If you don't think hospice is changing everybody to morphine, you're kidding yourself. And because it's fun and effective. We know that when we rotate opioids, it helps. And we're going to talk about why that is, okay? Because we're still talking about the same mood receptor. So why is this opioid working better than that one? Why we should not rotate it. We're already on the best at opioids. So let's say we have someone on Suboxone and we really don't want to put them on another drug. There is no other Suboxone, right? Suboxone is the only Suboxone. It's the only drug for Suboxone. So I don't know what I'm saying. You get what I'm saying. Why should we not rotate? There's no real benefit in keeping the OME low. So in certain patients with end-stage cancer or advanced cancer. Whether a person's on an MED of 100 or 200 might be rather irrelevant because they're not really developing toxicity at those doses, and they're doing great with this opioid. And why would we rock the boat? They've had prior side effect issues with other opioids. Some people just do not do well with some opioids. They get itching, they get nausea. And given the history, we just want to stick with this one. Or cost. Cost is a huge one. Morphine's cheap, oxy's expensive, fentanyl's super expensive. And so insurance reasons are reasons why we often can't rotate. Okay, so opioid conversion rules. I have this on that little opioid conversion thing that I sent you. It's in very tiny print at the very bottom of the side that has common opioid doses. So number 1 is assess the patient in pain. Number 2, determine the current OME. Number 3, we want to ask ourselves, what's the goal OME? So is my patient comfortable where they are, or do I need to increase 50 to 100% because they're still in pain? Number 4, and we're going to talk about this, I need to drop for incomplete cross tolerance by 25 to 50%. Number 5, I need to decide on my new opioid, considering age, renal function, and cost, including if I'm going to start a long-acting. I need to convert, and then I need to reassess and reassess. I don't know what BOP means. Who knows? Okay, there it is.
Alex,
Yes.
there was a question in the chat about what about the Tylenol dose with the Q3 Percocets?
So what's 325 times 8? Hold on, I'll get my calculator out.
Around 2.5.
325 times 8 equals 2. Yeah, that's still under 3,000. It's 2,600 milligrams. So 325 times 8 equals 2,600 milligrams, still less than 3,000.
So there's your answer.
Back in my day, I'm just loving this statement. We had everything was with 500 milligrams, and the FDA changed it all to 325 for this very reason, because people were not really taking things as prescribed. They were easily hitting above that 4,000, 5,000 limit, and so they dropped it to 325 for this very reason. So we really have a lot more safety built into these short actings than we used to from the Tylenol standpoint. And maybe one day you too will have someone on Q3 hour oxycodone like I do. Not elegant, but it's sometimes we do what we do. Okay, here we go. Let's talk about incomplete cross tolerance. You're going to teach this every day to your residents, okay? So if I'm a mu receptor sitting here and I have seen morphine, let's do like Miss Robichaud. I have seen oxycodone for the last 6 months. I am not going to be as reactive to that oxycodone. I'm going to be like, hey, Oxy, I don't really care about you anymore. I'm not going to do my downstream cellular effects when you come around as often because I'm used to you and I'm not interested in any. Now, if I rotate to a new opioid, let's say morphine, all of a sudden that new opioid is really cute and cool to the mu receptor, and it's going to work better dose for dose, even though it's still an opioid. Now, there'll be some tolerance that will exist because that mu receptor has already seen oxycodone, but it's not going to be as strong as it would as if it was continuing to see oxycodone. There will be incomplete cross tolerance, okay? And so my new opioid is going to be 25 to 50% more effective. My new opioid is going to be 25 to 50% more effective. And that's not built into your conversion table. Okay, that's not built into your conversion table because you want to use your conversion table in acute situations too, where someone isn't tolerant. And so your conversion table is designed for purity. And that's why you have to know this stuff. Okay, so when you have someone at a stable opioid dose, you're going to have to drop them by 25 to 50% if you move them to a new opioid. Okay. Okay, do we have a question? When you rotate off a med, could you consider cycling back to the original med once told? Oh my God, yes. Yes, Jasmine. Yes. And I have patients, you'll get these metastatic prostate guys, they're still hormone receptor. They're going to live forever. They're going to live longer than me. And we might go 1 year, we'll do hydrocodone, and then the next year we're doing oxy, and then they go back to hydro, and then we're going back to oxy. We get that replenishment back after a few weeks or months. Does that answer your question? It's a beautiful thing. It's a beautiful thing. And this is another reason why we often like to have people on the same long acting as short acting. So if I have someone who's just on oxy, if they're on oxycodone and oxycontin for long acting, this leaves me a lot of options to rotate to later. Whereas if I put someone on oxycontin and morphine, I'm developing tolerance to both of these drugs, and I won't be able to take advantage of incomplete class tolerance later with either of these two drugs. Does that make sense? Okay. That being said, I since for safety reasons feel that having people with two bottles that both say morphine creates a lot of confusion for folks. And I'm kind of walking back that elegant argument in the favor of patient safety, but that's for you and you're intending to figure out during the year. This is why you can use hydrocodone as a short acting since it's not easy to get the long acting. Okay, but I digress. Okay, moving on. What is a conversion table? So I sent you a conversion table. Is that conversion table written by God high above and is perfect? No, all conversion tables are horrible. All conversion tables are horrible. Okay, especially the one that your attending probably is using, which they learned 15 years ago. At least the one that I gave you has some more recent data in it, thanks to Mary Lynn McPherson and the crew at MD Anderson that's doing a lot of conversion research. When you look at the conversion table I gave you, you will see that there's some values in parentheses and some values that aren't. The values in parentheses are more recent and probably more correct than the values that aren't, okay? A lot of people are like, well, I really don't need to use a conversion table. I'm just going to use a calculator. I've been using a calculator online and it works great. Please do not come to fellowship to use an MD Calc calculator. You have got to do this stuff by hand initially. When I'm doing big conversions, I like to show my work in the chart. I like to show my work so the pharmacist can see it who has to do this, fill this script, so the nurse can see it who has to give these orders. Like, let's do it right. Let's do it right and not use MD Calc. I don't know what MD Calc is put in there. I wouldn't trust it though. They probably just pulled it off of Google. Okay, Pearl, despite fear of morphine that many have, it is generally a weak opioid. So when you look at your conversion table, look how much morphine it takes to equal the same strength of hydromorphone or the same strength of oxy. People have a lot of hangups about morphine because it's used by hospice. Why does hospice use it? Because they're cheap. So you can try to educate that away if you think you can make strides with that, or just recognize it with your patients that morphine scares people. Okay, here it is. Here is the equal analgesic conversion table. I have sent this to you. Again, the values in parentheses are from Mary Lynn McPherson's book. These are much more recent and more exact. Note that hydromorphone conversions are directional. Could that be any harder? And so you can't, I mean, you can do both, but just be mindful of that. And moving from fentanyl should scare the shit out of you. It scares the shit out of me, especially when I'm moving to a fentanyl patch. And the range that's from different studies with fentanyl to oral is very broad. And so with fentanyl, you can use a conversion table, but I would also use the fentanyl duragesic package insert if you're starting a patch. That's my favorite way to do it. I like to do the conversion and then I also do the package insert, and then I find my happy place in between. All right, here's the card that I gave you. Here is the starting doses for opioid naive patients. Here's the conversion table, okay? And then here's some common generic formulations of opioids, and here's the opioid conversion steps, okay?
Are you able to hear me?
No, yes, now I am.
Can you pause that one? Sorry, we have multiple things going on. Are you able to go back to the conversion table? Okay, and other people might already know this, so I apologize, but could you just like, I guess, interpret for us, like, for example, the morphine line? So when you have like 25 oral and then parenteral, you have 10. So is it saying that, like, say you go from 25 milligrams to the other one, then
Yes.
it's 10 milligrams?
So let's talk about, so everything here, everything within my little cursor is the same strength. So 25 or 30 of oral morphine is the same as 10 of IV. 25 or 30 of oral morphine is the same as oxycodone 20. 25 or 30 of oral morphine is the same as fentanyl 0.15 milligrams. Does that make sense? So everything
Yes.
written on that is the same strength in an ideal world. Okay.
Okay. So yes. So say you're doing like hydromorphone 1.5 and then you want to transition to like IV codeine, then the 1.5 would be equivalent to the 100.
That's right.
Okay.
And that doesn't take into consideration incomplete cross tolerance.
So
Okay,
then you
remember
would reduce.
That is not right. So if your patient's opioid tolerant, you would reduce. If the patient had a hip fracture yesterday, there is no tolerance. There is no need to reduce.
Okay. That makes sense.
Mm,
Okay.
mm.
Perfect.
Okay, so let's talk about, well, we're going to get to some conversions in a minute, okay? Just so you have it, you know, this is a cheating bastard dirty conversion table that's a little cleaner. This is probably, you know, doesn't have a lot of decimals in it except for fentanyl. So this could be one that you might try to sort of commit to rough memory to seem really cool on the wards. But even on your boards, you're not going to have these memorized, okay? You're gonna be able to pop up a little conversion table on your test. So there's really no reason to commit this to memory. And you might, when you get older, your memory fails. And so teaching yourself to refer to a card is not a bad idea. The most recent hydromorphone data I'm using here is from Reddy et al. That's the group out of MD Anderson that did some really great work looking at hydromorphone. And that's why these numbers might be different than what your attendings are using. This is a table I've adapted from our fellows who learned it from Michelle Christopher, who's the APD here at Tulane. And it's just a nice table that has the cost and the onset and duration of different drugs. I just, in my mind, I think short acting oral, it's going to be 3 to 4 hours, maybe 6 if I'm really elderly. IV, it's going to be maybe 3 hours of duration. And then most long actings that you take orally are going to be 8 to 12. Morphine can be dosed, long acting morphine can be dosed Q8 or Q12, and long acting oxycodone is dosed Q12. These are things you're just going to learn this throughout the year, and I'm not going to go into all these details. This is a nice table on dosage adjustment based on glomerular filtration rate. You can see that typically when we have a GFR of greater than 50, we're going to be okay with most doses. But once we get to less than 50, we kind of want to be mindful and maybe half our doses. That's when we might use an oxy 2.5 instead of a 5, a morphine 1 IV instead of 2, if that makes sense. There is no shame in looking things up. I mean, and that's what I love too about this is an aside about the boards. I love that the boards now allow me to look things up as an old doctor. Because I look things up all the time. All right, so we're gonna rotate to morphine short acting. Okay, we're gonna back to Miss Robichaud. God, I barely remember her. Remember, she had the metastatic breast cancer. She was taking the Oxy Percocet, the Oxy Tylenol 5. She was taking 6 doses a day. She was having to wake up at night to take a dose. Her OME was 45. We weren't bold enough. Her pain was good. Her pain was controlled. So we were at a good pain level, but she just really felt like it wasn't working quite as well. Okay. So this is Miss Robichaud again, just like we talked about. And here, and I've dropped all of the steps that we're going to do for Miss Robichaud. That's also on your card. Okay. Again, and we've said this 3 times. When we increase opioids, we typically increase by 50 to 100% of the daily dose, sometimes less, really more. We're not going to look at that again. So this is how you can use an opioid conversion table. Okay. Some people like to say, well, this is 3.5 times stronger than that, and they like to multiply. I like to do cross multiplication because to me, it feels really safe. So on the left-hand side, I'm going to write the existing relationship between the drugs. Okay, so from my conversion table, I'm going to look down and I'm going to see 20 milligrams of oral oxy is the same as 30 of oral morphine. Okay, and I'm going to write that down and I'm going to go equals, and then I'm going to say what I have now. Let's say I have 30 milligrams of oral oxy, and I want to know how many milligrams of oral morphine does that mean? So I take the equation and I put it write it like this. And then I take the 2 values that are across from each other that both have values. I multiply those times together and I divide by, do y'all remember this? You divide by the one on top. So here I'm going to multiply 30 by 30 and divide by 20. Do y'all remember this from 4th grade? A lot of us don't. So 30 times 30 divided by 20 equals 45 of oral morphine. Okay, if you don't remember cross multiplication, you can use the ratios, but I find this to be easiest. Okay, so we figured out she's on 45 of oral morphine. We're going to assess the patient and her pain, determine her OME is 45. What is our goal? Oh, I'm sorry. I said she was comfortable. I guess when I wrote this, I decided she wasn't fully comfortable. So we're going to go slightly higher if she's not fully comfortable. In the outpatient setting, I tend to go up by 50%, not 100%. If you're dying, you get 100%. If you're outpatient and you're walking around and I'm not going to see you tomorrow, you're going to get 50%. So if my OME is 45 right now, and I'm increasing by 50% because she's still in pain, that means my goal OME is 67. Does that make sense to y'all? It's not an exact science. You could write 60-70, 60 to 70. You could write 75. Just get somewhere in that ballpark, okay? Then I'm switching opioids and she's tolerant. So I'm gonna drop for incomplete cross tolerance. Because she's elderly and lives alone, I'm dropping by 50%. So now my OME is back down to 33 to 45, depending on how much I drop by. I'm going to decide on a new opioid. I want morphine immediate release. I'm going to consider her age and renal function and her cost. The lowest pill dose is a 15. It's only going to last 4 to 6 hours. I could do 7.5 or 15 milligrams Q4 to 6. Okay. So if I did 7.5 times 6 doses, that would be in a day, 7.5 times 6, that would be 45 milligrams. So that's within my OME goal. Okay. So I'm going to take that goal of OME of 33 to 45. So let's say 40, divide it by 6, which is how long a short acting lasts. And I get about 6 milligrams a day. And so the closest I can get to that with morphine is morphine 7.5. Does that make sense? Why would I not do morphine 15 Q8? Why would I not do morphine 15 Q8? OME is the daily allowed. Yes, Danny. So the goal OME is what I want to make sure is available to her every day so that she can have pain control. That's right, Charmy. That's right. It would stop working after 4 to 6 hours. So if her pain is around the clock, if I say you're going to get a morphine 15 Q8, I'm pretty much assuring that she's going to be in pain for the tail end of every dose. So I want to dose something Q4 to 6. Okay. Everyone understood? Good. If we were starting a long acting, which we discussed why we aren't, we would take the goal OME and we would put 2/3 of it into the long acting. So we never put the full OME into the long acting. We only put a portion of it, about half to 2/3. Okay. Questions about that? Do I consider this patient? So Sky, she is just opioid tolerant. So her OME is 45. We talked about how opioid tolerant patients are 40 to 60. So she is opioid tolerant, but she's on the short end of it. Okay. So for me, because she's outpatient and elderly and lives alone, I'm not yet comfortable starting a long acting. Plenty of people would be, okay, especially, so plenty of people would take 45 of that OME. They would put 2/3 of it, which would be 30, into a long acting. So you would also start MS Contin 15 BID. That wouldn't be what I would do, but that would be what some people would do. And that might be right for your patient. It's just not right where I work with my patients. We all work with different types of patients in different settings, and we all have our different levels of comfort based on our experience. Okay. This is fun. Convert, reassess, 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 reassess. Okay. So when you do a conversion outpatient, you want to make sure your patient can reach you. You want to make sure that maybe you're calling in a week to see how that patient's doing. You can like have a little day planner and plan to call that patient during your next clinic and check in on them. I used to do that, and that's how I found out that my fentanyl patches were landing people in the hospital with broken arms. It really helps to do that because it's really going to refine your practice. Okay, now you're going to do it. Okay, here we go. Miss Robichaux returned 6 weeks later. She is status post a pathological fracture of her humerus, and she got it fixed at an outside hospital, but her pain has worsened with worsening additional mets and debility. She's taking the morphine IR 15 milligrams 5 a day. So a lot of patients will do this. She on her own decided the 7.5 wasn't enough, and she's up to a full pill a day. It's not because she's diverting. It's probably just because she was hurting. Okay. So she feels she's chasing her pain, which runs from a 6 to 7 out of 10 most of the day. Her pain is deep and aching. So that's important to understand. The pain changed, this neuropathic, because neuropathic pain isn't going to respond super well to opioids. And she just feels a good night's sleep would help her the most. You decide to do what? Now show me how to do it. Okay, so what can we do here? We are taking 15 milligrams 5 times a day. She's not sleeping through the night. Her pain is not well controlled. Okay. We can dose increase. We can convert. We can consider a long acting. Okay. These are all options for us. Okay. When we don't know what to do, or as we're thinking to it, we're just going to start calculating OME. That's always the first step. So let's calculate an OME. Starting a long acting is the answer here. So let's ask why. Why is starting a long acting the answer here? We have a lady who's taking 75 milligrams of morphine a day. Okay. She's chasing her pain. All right. She's really not able to get comfortable, and she's probably watching the clock to take a pill. We are well above opioid tolerant, and so it's time for a long acting for most patients. That being said, I have patients who just can't do long actings because they take them like PRNs, and I might have this patient on Oxy 20 Q4. You break all your own rules, but on the test, the right answer is to start a long acting. Okay, so her OME is 75 milligrams. She's already on morphine. She's already on oral morphine. We don't have to switch her to OME. She's already on OMEs. We just have to figure out how many pills is she taking a day. We have to ask her that. We did. She's taking 5 a day. 5 times 15 is 75. Is she in pain? Number 2, we assess the patient. Is she in pain? Yes. Her pain is a 6 to 7 out of 10. She's not comfortable. So we're going to increase that OME goal to by 50 to 100%. That gives us, depending, oopsie, on which we use, sorry, I need to minimize the screen, 112 to 115 OME is our goal. Let's put a half to 2/3 of that in a long acting. So that's going to be 75 to 100 milligrams in a long acting. Long acting morphine can be dosed twice a day or 3 times a day. Okay. Unlike Oxycontin, which is just twice a day. So we could do 30 twice a day. That would get us to 60. So pretty close. We could do 33 times a day. That would get us to 90. So well within that. We could do, those are kind of our options there. Okay. And you choose based on what you know about this patient, based on her renal function, based on if she lives alone or with someone who could drive her the next 3 or 4 days while she's starting this. Whenever someone's starting a long acting, I like them to do it when they're not going to be driving for the next few days. Again, how long does it take us to hit steady state? 4 to 5 half-lives. So I'm looking at MS Contin. I'm saying your half-life is 12 hours. I want to see you for 2 days, not driving any kind of heavy machinery till we hit steady state. Okay. So we're going to start MS Contin 30 BID. Then we're going to put 10% of her total OME in a short-acting single dose. Now that's just something you're going to have to learn. A lot of people will say, well, I'm going to take, if I'm going to do MS Contin 30 TID, that's 90. And I'm going to subtract 90 from 112, and I'm going to have another 20 milligrams of OME she can get in a day. I'm going to divide that by 6 so she can have it Q4, and I'm going to end up with MS Contin 30 and morphine 5. Don't do that. That morphine dose immediate release is way too small for the amount of long acting she's on. It's better to just figure out your long acting dose on one side of things, and then just do 10% of your total OME in a short acting. Okay. So that means that she should get, for instance, 15 of MSIR Q4 PRN. We never schedule the short acting when we're starting a long acting. Okay. Because the safety is built into the short acting being PRN. If we've overestimated our long acting, if we truly didn't understand her clearance, the fact that she's not taking her short acting is what buys us safety. Does that make sense to everybody? Okay. I know this seems a little overwhelming. Could you have done something else? Of course, you could have done Oxycontin, you could have done a fentanyl patch. All right, we got to finish up. Oh my God, it's 1 o'clock. If y'all need to go, please go. Miss Robichaud returns to the ER 5 months later. She's had a change. She's now febrile, respirations 32, O2 sat 82, hypotensive and tachy. She's lethargic and rouses minimally to voice. 3 weeks ago, she was told by her oncologist that further chemo was not recommended and she needed a break until she could get stronger. Over the past week, she's been bedbound in a diaper, but until today, still eating and drinking a food bites and sips and able to swallow. Her home meds include Oxycontin 60 BID and oxycodone 15 Q4 PRN. You ask her partner, and she was taking the long acting as prescribed and about 2 doses of the Oxy IR a day. Okay, so we have a problem here. Miss Robichaud is dying. She's not able to swallow, and she's on a lot of pain medicines at home. What do we do? You have a goals of care conversations with her son, and he's clear that his mom knew that death was coming and would want comfort care at this time. What do you do? What about all those pain meds she can't swallow? What if he wants to take her home today? Okay, can we handle this? You bet we can. I'm not gonna do that right now. So I guess we're gonna have to figure this out on our own. So the first thing to do is to calculate her OME. Okay, so let's start by doing her OxyContin. 60 plus 60 is 120. 15 plus 15 is 30. So that's 150 milligrams of oxycodone. Okay. Oxycodone is 1.5 times stronger than morphine. So the morphine is going to be a higher dose than the oxy by 1.5. So if we do 150 by times 1.5, we get 225 of morphine. Is she comfortable? Is she in pain? Assess the patient. Is this our goal OME? No. Why? Because she's because she's breathing 32 times a minute. And that is not considered comfortable by us. We would want her breathing to be calmer, preferably less than 20. And so we would say that she is short of breath and that opioids are the standard of care for shortness of breath at the end of life, and we need to increase by 50 to 100%. So 225 times 1.5 again to increase by 50% is 337 OMEs. What medicine can we use at the end of life for someone who's unable to swallow and needs to go home? Roxanol. Roxanol is morphine concentrate, 20 milligrams per ml. You dose it at least at the max every 4 hours. Do we drop for incomplete cross tolerance? Yes. She's likely been on the oxy for some time, so we would drop by 1/3 to 50%. So since she's dying and I'm generous, we're going to drop by 1/3 and we're going to get to an OME of about 200 as our goal. We're going to divide that by 6 for Q 4-hour dosing. And we're going to get 33. So I need to get 33 milligrams of morphine into this lady every 4 hours. That's going to be Roxanol 30 milligrams, which is going to be 1.5 milliliters since it's 20 mgs per ml, tickled into the side of her mouth every 4 hours. One of the tenets of end-of-life care is that we assume if you had the pain before you were dying, that you have the pain now. Okay, we don't assume that your pain goes away just because you're dying. We don't want Miss Robichaud to die in withdrawal in addition to dying, which is what often happens when patients come in who are on long-standing opioids and they're actively dying and unable to speak. Morphine 2 milligrams IV Q4 hours is not the right answer. Okay, so we're going to give her 30 milligrams Q4 hours. I'm going to have to stop there because we've reached time, but please know that I really enjoyed sharing this time with y'all, and I'm sorry that I went over.
Thank you, Dr. Leigh. Yeah.
I do want to remind everyone that there is something beautiful called a buprenorphine, and this talk, it's outside of the realm of this talk. But one of the exceptions to starting opioid naive patients on long actings is Butrans patches, okay? We can start a Butrans 5 patch in someone whose OME is less than 30 milligrams a day, okay? So just keep that in mind for some of your patients, like maybe in a nursing home where we really worry about patients getting the meds they're prescribed. But you'd have to be in a healthcare system that can allow that, okay?
Buprenorphine, like Butrans patches, has replaced my 5 of methadone BID patients.
Yes, I think that's great because we've had a lot of nursing homes that have gotten very weird about methadone. Like even when we're using it for pain, they won't accept a patient on it because they assume that they're, a substance abuser, or user in their mind, a person who uses drugs, which is just so sad.
I also kind of feel like this is all part of the opioid pendulum, I like to think. In the 90s, they swung way too much in favor of opioids. Then there was a backlash to that, which was correct, but they went too far going against opioids. I think we're going back a little more in favor of opioids, and maybe eventually we'll find just the right balance.
I sure hope so. And I think buprenorphine is going to help us get there. And I'm hoping we have a talk on that soon. I know I was told by someone who attended the AHPM last year that a lot of places in the country that have a ton of opioid deaths are using buprenorphine first line for cancer pain just because they don't want to put full agonists out there into the community. Which I think is wonderful. I will say that I wish they had smaller dose tablets for our opioid naive patients that were short acting, because I'm sure y'all have found too that it's hard to start an opioid naive patient on the tablets. They're just too big of a dose.
So everyone has a little bit of a break. Before I let you go, I did want to mention Dr. Glass put this in the chat and Dr. Leigh didn't read it. But Dr. Alex Leigh, was the recipient of the 2022 to 23 Tulane Hospice and Palliative Medicine Fellow Elected Teaching Award.
Oh, thank you.
So, and I'm sure y'all all understand why she got that award after listening.
Not afraid to make a fool of myself for the point of y'all remembering something.
So this is a stretch break. We have until 15 after the hour before our next lecture starts on the other link. I did that so that I can record the lectures, and it's a lot easier for me on the back end. So I'm sorry about that. Take a couple minutes, take a break, stretch, and I'll see everyone on the other side. Thanks to everyone for being here. Thanks, Alex. Awesome.